talked about it because we've discussed it. If it is a fungal, if it's bacterial, if it's some trauma, we talked about those things. This is just um, going through it more with these things. So, yes, there's a lot of names in here, so we will see those things. Again, of anatomy stuff, we know that we have the nail plate, hard, translucent, the dead keratin, that would be the stuff that we got to cut off, right? We can have the matrix, that is the synthesis of that nail plate, lanula, of the white half moons. How many of y'all have the white half moons on every single one? Anybody have them all? I do, and it means you're special. So I've always had it, and one of my kids, my daughter, the youngest one, she has it too. So that's why she's special to me. And my other three, yeah, something is wrong with y'all. But yeah, it's rare, and so, but you all will have at least one, and you know where those are at. The nail bed, it's some of the peroral ridges, okay? You can also see some of the small the blood vessels, which if you do have some trauma, that'll all bleed out, and then we'll fix those things also. That the hyponychium is some of the short segment of that line that is at the base that you can see that is of the skin, and it's not of the nail. Well, yeah. And then the cuticle. So you have seen all of the beautiful things here. Sometimes you can have some of the normal variants, but you will still, if you see this, if they're having some symptomatic issues, then you can still do some of the KOHs, you can do some of the cultures just to make sure that it's good to go. If they're coming to you and like, this hurts or that hurts or that kind of stuff. So these are some of the different the signs and nail disorders. So the stuff looks bigger to you, but I'm going to lean over and stare at my thing, just like Mr. Booth. So you can see the subungual of the hematomas, which we will be treating that. The pincer nails, oftentimes we see those with, well, we don't see them, but it's common, the pincer nails, if it's a ballet dancer, right? Because they're always up on that, everything is like squeezed, and yeah. And then we see all of cirrhosis of the pitting, and yeah, we're gonna go over all of these things. So here with psoriasis, so you can see some of the oil spots. I have like one or two of those things. But onychiolysis, that is just some of the yellowing of the nails, and it's more of the distal aspects. I have them, small ones on my thumbs, but they're there. Once my psoriasis started, and I wasn't on the medications and stuff, then it would be more like my entire thumb. And I was doing all of the physical exam with y'all, and I would have to tell everybody, that is not fungal. Don't think that I'm touching you weird and odd, because it was embarrassing. There's more psoriasis that is of entire of the nail plate that will have some of the onkyo underneath of the nail, but you can see all of the lines, all of the spots that are there. So that's psoriasis. Lichen planus, it's most common if you're going to be seeing, or you will see the longitudinal grooving and ridging, right? So it's up and down there. We could also have some adhesions of the proximal of the nail fold. So we're going to see that in the pictures coming up. And it could actually scar it. So if you have the treatments of the LP, that can stay there. So you can see that on the proximal aspect. We could also have some nails that are having some of the drug induced changes. So we just talked about it, about the chemo, right? So the chemo can cause that to have that, because all of the medications that are going to give you the alopecia or of the hair loss, it can also affect the nails, okay? Also with the tetracycline antibiotics, it can cause that, okay? So here's what it looks like if we are using the tetracycline. Here's one, we talked about the cancer aspect. That's what it can look like with the melanoma that is up and under the nail bed. Hutchinson sign. That is what we are seeing on here. That is indicative of the melanoma. All right, now here is the fungal stuff, right? So of the tinea unguiculum, that is onychomycosis, that we will be doing some of the hand or foot, right? So we're having some stuff in here. That foot right there is widespread. It's almost every single one how it's looking. So y'all will probably know that we're gonna do some of the oral the medications, okay? For us to prove that this is onychomycosis, we could be doing the KOH, okay? If the KOH isn't pointing it out right away, then we can actually take one of our blades, scrape it all off, and then send it off for the culture, okay? KOH. I talked about this, right? So the 15 scalpel to scrape it all off and then send it away, okay? If we're having onychomycosis, it is most common if it's on the distal aspect, okay? So that's how come we can actually do the scraping, because it's on the distal aspect, so it's easier to do that. If it is superficial, right? So it's not up and under the nail bed, then it's not going to be yellow, it'll be white because it's on the outside. And then we can also have it, the proximal stuff, that will definitely not to have some of the oral, because we're not going to get all of the topical stuff if it's only the proximal aspect. So treatments here. Oral agents, the one on top, terbinafide, 250 milligrams every day for 12 weeks if it's on of the toes. If it's on of the fingernails, then we should only have to do that for 6 weeks because they're smaller. Okay? Terbinafide, that has the highest cure rate than the other ones that are out there. Okay? With all of these treatments, we have to monitor for the CDC and the LFTs because they can affect on those areas. You can see the other azole that can be used, but the higher cure rate is with terbinafine. Here's the topical one. So we would use these if it's only on the distal aspect. We oftentimes will teach some patients how to use a scalpel that is opposite. It's still sanitary, but you use the other side to put the topical cream or ointment and push it up and under. We would have to teach them that, okay? For mild or moderate, onychomycosis of the fingers and toes, and it's not spread all the way up, right? So we talked about the proximal aspect. We can't get the topicals all the way up there. Jublia, that's there. It's also one of the topical things. Prevention. We talked about how we have to, not have any of the trauma. If we're growing up, we're not using the same shoes that we had when we were 6, and now we're 8, and we're smacking them all. The picking of the nails. To rotate that, keep clean and dry, which is pretty much everything dermatology that we've talked over and over. Protect your feet in communal showers, right? So we have to remember in BMT how we would get the nails. If you're at a gym, nails, I said nails, of the sandals, if you're at a gym, exact same thing there. Keep your nails trimmed, short. So here is of the superficial, so we can see of the white aspect. This one right here looks a little bit more superficial because you can see of the other stuff and it looks like it's some crusting. This one right here, like I said, it is all of the other ones, so we would have to use some oral. But we know what the highest rate for that one is. There we go again. The next one, again, Mr. Booth put it in and close your eyes. Because that, oral and, let's cut all that shit off too. All right, so are they having some of the defects because of chronic exposure, right? So as you can see, if it's use of the nail polish, if it's brittle, we're oftentimes seeing these with our females who make or get beautiful, beautiful long distance nails. What's the name of that on of the Wicked? She was like the green one. Yeah, she's got some long ass nails. I don't even know how y'all can do stuff with those long things. Anyways, all right. How do we treat this? Rehydrated, moisturizers, lubricants. We will be doing protective gloves, and then we can also do some of the B7 to just to build them up a little bit. So what if they had some of the trauma? They could have some of the lysis again in women with long nails. Okay, so the treatment, remove it off, and then we're going to be using some of those things there. Nail biting. There are individuals in the world who like to bite them all the way down to, One of my best friends, he does that, and I see him bite his nails more than he bites food. It's like, I said foot. Myophagia, y'all know it. All right. It can also be causing some of the hangnail, right? So we can do some of the cutting, some of those things that happen. Nail biting, you can see how it's going all the way down to where there's no trauma with your teeth. Okay. One of the traumas that y'all are going to treat frequently on our active duty population are ingrown toenails. Oftentimes individuals, this can happen if they're cutting of the nails and they cut it too deep and it starts to grow back up and under. That can be one of the things that would have to do. So you can see over there on the medial aspect of the nail, it's tucked up and under, and it can be causing some infection that is in there as well. Swelling, pain, purulent discharge, improper nail care, like I talked, or some trauma. Okay, partial or full nail removal. This is why I talked about. Y'all will see this a lot. It's because you will be doing all of the lidocaine up and over, cutting it all the way up with a scissor or a scalpel, and then yanking that entire thing out of there, and then treatments on those things. So you can see that there is the medial aspect. That happens more frequently on the medial aspect. That happens. More trauma. What if we have a hematoma? That one right there is pretty much all over. Usually, if it's severe, then it can bleed all the way up and out to the distal aspect. What are we going to have to do with it? Well, we're going to have to take a heated of a paper clip and stab it into there. We do have some equipment now that we don't have to do it, like we're taking a nail clip out of our office and then using a lighter to do that. If you're in an area that works, but we now have some to where we just push the button, heats it up, and then we stab it in. Okay, so we have to let all of the blood out, and why? Because if it's bleeding and bleeding and bleeding and it's building up, then it's going to start to have the swelling of, some more trauma. So what would it look like? That is what it would look like right there. So that is you over the blood area. You heat it up and put that of a circle there into it. You will, as it starts, see some of the oozing of the blood to come out. Or you could squeeze it and try to get it out. But it's not going to be all gone. Eventually, it'll feel better. Okay? Habit tick deformity caused by biting or picking of a section of the proximal aspect of that. Okay? So it starts to build up the longitudinal band with the yellow discoloration. We can see these with individuals who have some of the OCD, right? So they just always have to do something. So they're just playing with their nails over and over, scratching at them. So, a habit tick deformity could be psychiatric. Treatment, stop doing it. Let's get you on some psych medications or something. So, psych. So here's the pincer ones. So we talked about it. It's all of the inward of the folding of the lateral edges. It will hurt. It's caused by of the shoe compression, right? So I talked about the ballet dancers, right? Yes, they have to stand up on the toes, but they also have to do that. It's also seen with some of the females who wear stilettos or, you know, some of those other bougie ones that are just squeezing them all over, and yeah. Treatment, let's take the nails off, not use those shoes, and let them grow out so that they do not look like that. Don't pinch them. That one, yeah, wow. So here's the paronychia, okay? Rapid onset of painful bright red swelling and proximal and lateral nail fold. This could be after some of the trauma, again, of the biting. Stop biting your stuff. And manipulation, okay? This will form of a small abscess, IND. Again, we will also use some of the staph antibiotics. Take them away. Just like with the nail, it would be of an IND exactly the same way, right? So we're going to lido it first, lift it up and out to get the pus on out. So what does it look like when you can see the pus in there? It looks just like that one right there. So it'll be to open it up, squeeze it out, and then we're going to put them on of an antibiotic. Again, IND and antibiotic, anti-staph antibiotic. Pseudomonas. So with the oncholysis, that will expose of a damp, macerated space, and then you can get some of the growth of the Pseudomonas. So we'll see that nail plate turn green, black in color, and the treatment here, acetic acid, just like we were talking about when we were into of the fungal stuff. Vinegar. If we do have to prescribe of an antibiotic, then we can go with some Cipro. But let's start with the vinegar first. That is what it looks like. Green to black. You can see it again there. We're going to do a little bit more than just of the vinegar with that. Bowes lines. Transverse depression of all nail that appear at the base of the lunulu. Weeks after stressful event has temporarily interrupted the nail formation. So basically, they were in so much stress that their nail was not growing out. So it was almost just stuck. And so that's when you can see the Bowes lines. No treatment is necessary because it is all going to grow out, and then once you cut your nails, it's going to be gone. You can see some more right there. So of that, the ring finger, there's not any treatment. It is going to grow out and go. All right. So one of the very rare ones is of a yellow nail syndrome. Before, during, or after some of a respiratory disease. That is an association that the respiratory disease, it's on the medications and stuff that, so it will also work with some of the lymphedema. So that's all of the spread down that causes the yellow. CNM patients, curved turns yellow, and all nails are involved. Treatment, you can use some vitamin E, oral or topical, if it is not spontaneously improving. So that's what it looks like there. Every single of the fingers have the yellow syndrome. Finger clubbing. I know that y'all have seen this in all of your other ologies, right? So heart and lung disease, cirrhosis, colitis, thyroid, right? So I'm sure that y'all heard from Miss Salyers last semester when she was going through the thyroid stuff. Distal phalanges of the fingers and the toes are enlarged to a rounded bulbous shape. Nail enlarges and becomes curved. And of that degree, just like you can see of the picture, to over 180 degrees. Treatment, there are none. We just need to be sticking with the treatments that we are providing, prescribing for those diseases up top. So it looks like that one there. It looks like these ones here. So, yes. All right, so that's the clubbing. Here are the spoon ones. Spoon, coilonchia, okay, lateral elevation and central depression, okay. It could be normal, but most often it's associated with the iron deficiency, okay. If that's the case, let's go ahead and correct all of the iron deficiency anemia. So that's what spoon looks like. You can use it, you know, to snort some Coke or, I don't know. Spoon nails again. There we go. We talked about the Bose line. Here is the Mies lines. Transverse white line in the nail plate. Again, associated with sepsis, renal failure, arsenic poisoning, hepatic failure, CHF, chemo. So this is all one of the things that if you see these ones, you could think, oh shit, let's go ahead and do some labs to look for all of this stuff. Just like the one we just talked about, there's no treatment that we can do. We just have to stick with the disease processes that they're going through so that we can get this to go away from a bit. You can see them there, it's more of the distal. All right, so we talked about Bose, Mies. Here's Terry's. White or light pink, but retained 0.5 to 3 millimeter normal pink distal band. So it looks normal, but then you can see that of the line that is over there at the distal aspects. Again, cirrhosis, chronic congestive heart failure, adult onset of diabetes, and age. Again, you can see that there of the white. So there's some of the names there, right? So like at the end, we were talking about Bose, yellow, Spoon, Mies, Terry's, All of those ones are newer ones that we have to look into the diagnosis, so labs and everything, but if they are already on the medications there, then we can press on. All right, any questions? I'm gonna go talk with Dr. Casimir, and if she's gonna be done early, then I will do both of the lectures tomorrow, and then on Friday, we'll do a review of these lectures. All right, I will see you tomorrow.